today. We've got some people joining us in the room here today, and we've also got some people joining us on Facebook as well. And welcome to Dr. Alan Bonder, who's joining us today from Boston. Thank you so much for taking the time to join us again, Doctor. It's been a little while, hasn't it, since we've had you on, so it's really nice to have you back. Just before we get started again, just to remind everyone that Facebook's a public forum, so just be careful with what you're posting in there. You've got a bit more privacy in the room here with us in Click Meeting, and that these Q&As don't take the place of a consultation with your own clinician. We're just given general medical information here and not specific medical advice. So we'll make a wee start on the questions that we've had sent in, but I'll keep an eye on our live streams as well to see if we've got any questions coming in live for us as well. So I'll pop over to the first of our questions that have came in. So we've had a question about gum health and asking if PBC can affect gum health. They've been told it's a symptom of liver disease, and if it is there anything that they can do to help ease the pain and better protect their gums?
Good question. I mean, not a specific kind of related PBC condition, but other gum issues that can come up is if there's certain vitamin deficiencies related to other conditions, may related to PBC, for example, celiac disease, losing a lot of vitamins. That will be it. But again, the answer to the question is not related to PBC. Not
connected. That's great. We've got a patient who was diagnosed with PBC in 2019, but had previously had positive AMA tests in 2009, 2010, and 2012. They've recently had their gallbladder removed and then subsequently had to have 2 sphincterectomies after they found out, and it was following that in 2014 that they confirmed they confirmed our PBC. They're concerned about doing another ECRP because they're saying it's high risk, but she's suffering very bad from bile reflux, which can be seen on the scan, and it's given her severe burning after any attacks that she has. Her doctor has spoken to her about starting a second-line treatment, and it's UdCA that they're considering. She's had a look at that and looked it up, but the leaflet says that it can cause liver damage, and she's a bit concerned that that's potentially going to make her worse. So I suppose just a general question around the concerns about starting UdCA, but also that she's seen in the leaflet that it can potentially cause liver damage.
I mean, this is a great question. So UdCA, which is obeticholic acid, is a pretty well-studied drug. It's being in the market or being used since 2016. I think I would say there's kind of few contraindications, but the main one is complications of liver disease, such as portal hypertension, like varices, ascites, or encephalopathy. In 2021, there was a black box warning from the FDA saying that some patients died related to complications of liver disease. So again, it's a safe medication, and patients with cirrhosis, we call them child A, we call them compensated. It's safe to use, but we need to adjust the dose. But I would say it's a well-known study medication. It's currently one of the second-line therapies approved for therapy who don't respond to conventional UdCA dose. So again, it is, advised to use this medication, but I think should be prescribed with the supervision of a liver doctor who really knows the indications and the contraindications in patients with PBC.
That's great, thank you. We've got a patient whose platelets have stayed around 120,000 for 2 years, and they're asking if this could be due to their PBC.
The answer to the question is yes, not directly. So the PBC does not affect the platelets directly, but when someone has any type of liver conditions and their platelet count is below the 150, which is the normal range, in the hepatology world, we are concerned that these patients are developing cirrhosis. So I think this patient should be kind of addressed and should basically get either an elastography or FibroScan or some other kind of test to determine if the patient has advanced fibrosis or cirrhosis.
Great, thank you. Patient whose ALP has reduced to moderate at 175 and GGT is now 114. Does this indicate that I'm still having damage to my bile ducts?
Great question. So I don't know the baseline, so we should actually, in that question, I don't know if the full ALP started at 300, 350, 400, now it's 175. Yep. It's really a great improvement. If it's 175 and now it's 175, maybe it's time to look for second-line therapy. So again, it depends on the context of the ALP. And we have other tools to see if there is certain damage to the liver. For example, it's a one study tooled the elastography, we call it the fibroscan, to see if there's any damage, and then the stage of scarring can be addressed and see if that correlates with the damage of the liver with the PBC.
Great, thank you. We've got a question around osteoarthritis and if it can cause an increase in ALP.
Good question. So the ALP has a bone kind of subtype of enzyme. So again, I don't see in patients with severe osteoarthritis elevations of ALP, but we do see that in patients with, for example, vitamin D deficiency or bad osteopenia or osteoporosis. And then in those patients, treating the underlying bone issue will improve the ALP, but also there's also a subtype of testing that we can do to assess if the ALP is coming from the liver, is coming from the bone, or from other sources.
All right, so there is a way of telling which is the cause. I didn't realise that. That's really interesting. Thank you. When URSO is declared to be working, does that mean blood work should return to the normal range or close to normal, but not always in the perfect range?
Another really important question. So UdCA or URSO is kind of like the currently therapy approved for PBC. And the way we know it's working is we evaluate the patient at the time of diagnosis, the ALP, and we follow it for at least 6 to 12 months. And if the ALP goes below a certain threshold, I mean, we call the poise or the 167 above the upper limit of normal, then we call those patients responders versus non-responders. So that's one thing, but I want to emphasize that UdCA or URSO, it is not the treatment of choice of symptoms-based related to PBC. So some patients will experience improvement in their labs, but they will not show any improvement in their symptoms. And again, it's so important to discuss this with your, gastroenterologist or hepatologist, because you should be looking for different types of therapies.
Great, thank you. Another question about ALP, asking if it's significantly raised over 1200. Is that not so concerning if your bilirubin remains well under the upper limit of normal at 5? And how long would a very ALP and above to become concerning or dangerous?
Again, this is also very important questions. I think there's been tons of research looking at thresholds, what is dangerous and what is things that we worried about. So, for example, if you look at the kind of things that we looked at, it's called the Global PBC, which is actually a world group that publishes from every part of the world with PBC outcomes. And when the ALP is elevated 5 times above the upper limit of normal, so if it's 120 times 5, so we think within the 500s, your chances of progressing to complications, liver disease are higher. So if you are 1200, this is a kind of a number that I'm worrying about, and then we should be looking at second-line therapies and looking what's going on, or other etiologies of ALP, what's not going down with therapy. So I think I would encourage that person to speak to their kind of healthcare providers, gastroenterologists, hepatologists, to see if there's any options for any other type of therapies if they're not on one right now.
Great, thank you. This one's a bit of a longer one, but we've got a patient who has had a history of chronic elevation of their liver enzymes for the last 7 years, ALP fluctuating between 111 and 214. And their ALT has also peaked at 159. So since 2023, repeat labs have shown that they're now all within normal range, apart from ALP, which is in the high to normal range. They've had an MRI and an MRCP, no IH or EH bile duct dilation, and the spleen was normal. Have you got the document there as well, Doctor? I just appreciate there's quite a lot of detail in this one. The hepatologist says a suspicion of AMA negative, so they want to monitor it with annual labs and a fibroscan. Thoughts on the need for a biopsy if labs are trending normal for the last year, although the ALP runs high? Should they push for a biopsy or watch annually as their hep suggests?
Good question. And again, it's hard to really kind of give you the right answer without seeing the patient in front of me, but I will give you a few kind of case scenarios. The good thing is the liver tests have normalized, but the ALP is a little bit elevated. And then the criteria to diagnose someone with PBC is 2 out of 3. You have a positive AMA, You have to have elevated of alk-phos or ALP. And if you don't have any of those prior to, then you need a liver biopsy that shows findings of PBC. So to diagnose negative AMA PBC, you will need a liver biopsy to prove there are PBC findings in that liver biopsy. So there are two things that we can do. I just don't know what it is the elastography results. If it's low, personally, I would actually basically follow those liver tests and see how things are looking for other things that would inflame the liver. There are medications, you name it. And then if, this continues to be elevated, at some point will be a good idea to decide if a biopsy is indicated. Again, I don't know the details of the clinical picture, but, don't know the patient is on aspirin, anticoagulated, or other comorbidities. But if in that case, a biopsy will give me the answer, I think it's a good idea.
Great, thank you. We've got a question around patient that have PBC and PSC. They've read some reports of an overlap syndrome between these diseases. They've got elevated liver enzymes and positive immunoserology, so ANA, AMA, and anti-PDH. Since the response to URSO has not been optimal, they've underwent an MRCP, which showed individual short strictures of the bile ducts. Patient now a wee bit confused as to which condition they might have and what might be the best approach if it is a overlap.
Well, this is a great question. So I would start with patients with PBC have an autoimmune condition. So there unfortunately are an increased risk for another type of autoimmune condition. And when you tie them up in the liver, for example, PBC is more common appear with AIH, autoimmune hepatitis, but also can actually go with PSC, primary sclerosing cholangitis. And as you describe in the scenario, they have strictures, meaning narrowings of the bile ducts. With the serology workup and the MRI findings, as well as the liver test, it's very hard to differentiate which one is acting more than the other one. So I would say we optimize treatment from one, for example, UdCA, see if the patient responds to UdCA, and if it doesn't respond, really trying maybe a second-line therapy can work. And then for PSC, unfortunately, there is no currently approved therapies, but I would say there is more data coming that, for example, the PPR agonists, which are basically the second-line therapy for PBC, such as elafibranor or seladelpar, will be used in clinical trials to treat PSC. So I don't know, I would encourage maybe to ask the question to the hepatologist to see that as an option. But this is a really tough case, and then I would say there is no really good answer to say which one is causing the abnormal liver test.
Okay, thank you. Excuse me. So we have a patient who's been prescribed URSO following their diagnosis, and they're taking 1,500 milligrams per day. They're having some trouble with side effects, and they're starting to feel, initially it was okay, but they're now starting to feel a bit trouble with side effects, and they're feeling sick. They've had a chat with their doctor about that, and because there's no alternative, the doctor suggested that they stick with that at the moment. Question is around, will the unwanted side effects diminish as the body gets used to the medication? And also a while ago, she also spoke to her consultant about bezafibrate as an alternative to URSO. Could that be something potentially to try?
Again, important question. So I think, sorry, I'm muting. Give me 1 second, sorry.
No problem. I'll just take the opportunity actually to let people know that are watching with us that we do have quite a backlog of questions at the moment, but we're working our way through them, so bear with us.
Sorry. So
that's okay.
Sorry, it's just like the phone. Again, it's so important to stress the differences, the importance, and how do we treat patients with PBC. In one side, we have what's just called disease activity. So we clinicians looked at their patients' numbers. We look at the ALP, the bilirubin, the elastography. And based on that, with the UdCA, we basically named the patients either responders or non-responders. So we give them UdCA, which is weight-based therapy, and then we look between 6 to 12 months to see if they respond to therapy. And if there is a threshold going below, they respond. If they don't, they do not respond, and then we start adding second or third line therapies in this case. And then in the other side, they are symptom-based therapies. As I mentioned before, UdCA does not treat symptoms, then we should be looking for other types of therapies. So what I'm going to say is patients who are having side effects from the UdCA, can get a second-line therapy just to treat their disease activity. And I have a couple of patients who basically UdCA will cause bloating, hair loss, recurrence itching, you name it. So those patients, I stop the UdCA, I put them on some type of other therapy, and they respond. And then I have the other type of patients who need more symptom-based therapy, where basically I add on, medications to treat their itching, medications to treat their fatigue, medications to treat their pain. So again, it depends what are basically the symptom-based therapy, and then we can decide if there's anything else that we need to do.
Great, thank you. I'm going to put, there's a patient, next question is about a surgery that a patient's had, and I'm going to put it in the box here because I'm not convinced I will pronounce it correctly. I think it is a bile duct reconstruction surgery. So in May, the patient had a surgery, and the surgeon took them off Urso after the surgery to see if they noticed a difference. They've had no difference. PBC has always been very mild, no itching, not terrible ALP numbers. Does this make sense that stopping the Urso has made little difference? What would be your opinion on that? Is that right? Is that bile duct reconstruction?
Yes, there is. And again, there's a lot of indications for this type of bile duct reconstruction. And I will have to look and see what was the indication for it. But that should not affect, PBC response or PBC issues in patients. Sometimes these patients, for example, have a little more of a bile diarrhea, because they're not absorbing it, but it should be okay. But again, it's very unusual. But again, personally, I don't see the surgery affecting the PBC response to therapy.
Great, thank you. So we have a patient asking, is it normal for PBC patients to have pain on the right side under their ribs on a daily basis and also bone pain? I haven't been staged yet and I've been on Urso for 5 months now. ALP has gone up to 179. Is there anything that my consultant should be doing? Again, I don't know what it was prior. I don't know what the ALP was prior to that.
So I think just again, Mo, you just hit up a really important point. So we need to know what the ALP was before starting therapy. And again, I want to just emphasize what are the symptoms that patients with PBC experience, right? So if you ask me what are the top 3, so fatigue is number 1, itching is number 2, and some type of abdominal pain is number 3 in the 10 to 15% of the patients. And the pain could be localized to the mid of the stomach, too close with the liver, which is basically under the ribs. And we really don't have a really good explanation for the pain. I would say in those cases, we should look for something else. Some of my patients, I'll get an ultrasound, make sure there's no stones. If I don't see anything, I'll move, do they have any acid indigestion? Do they have any history of taking medications that could cause an ulcer and they'll need an endoscopy? So what I'll do, I'll rule out everything that I can. And then after that, I don't have anything else. I'll tell you this is most likely related to PBC. Unfortunately, we know, and again, as I really explained it kind of in the last couple of minutes, UdCA does not treat symptoms. And I think we need to really kind of investigate what is the right therapy for patients with abdominal pains, which really don't have at this moment.
Thank you. Question around nerve pain in fingers. Could that be related to PBC?
No.
If someone tests positive for AMA, but ALP and AST are still normal, what would be done? Watch and see?
This is a really good question. And I would say there's really good, 2 schools of thoughts, right? So if you look at the guidance from the American Society of Liver Disease and the European ones, if you have a positive AMA and you have normal liver tests, your chances of developing PBC in the next 5 years is maybe close to 20 to 25%. So 1 out of 4 or 5 patients will develop PBC. Again, there is some really physicians who really say you have 2 options. One is you will need your liver test to be checked once or twice a year just to make sure you don't develop signs or basically abnormalities of PBC. And if you do, you start UdCA. And some of us say, okay, you should be starting UdCA preemptively to actually start the therapy for that. Again, also, I want to make sure to stress the importance of the right clinical scenario, right? If this is a patient who has rheumatoid arthritis and other autoimmune things, and maybe this is most likely the patient has PBC. Also, again, if it's a female in their 50s with itching, this could be the beginning of PBC. So again, I would like to, this depends on the context of the clinical scenario, but again, the two school of thoughts are really good approaches, and again, both of them are correct.
Great, thank you. We touched on it earlier when you mentioned about the main symptoms, but we've got a patient who's really struggling with severe itching. They've started on cholestyramine. Their ALP is at 485 and rising. Other bloods raised due to URSO stopped working after 24 years, so they've been diagnosed for a long time. They've tried fibrates, but that was causing kidney disease. They've been referred on to a specialist to look at potentially obeticholic acid or elfibranor. They were diagnosed at aged 28, now 45, also have Sjogren's and Raynaud's, and another few, as you mentioned, about potentially overlap of other things. Just really asking about if there's any other treatment that they could try for severe itching.
Again, important question, and again, the answer to that answer, yes. There's really a lot of new therapies in clinical trials and available that we can use to treat the itching. So OCA will be not my first choice because OCA as a side effect can cause severe itching. Up to 50 to 70% of people using OCA will have some type of itching. So again, that excluded that use of that medication. We do have the use of fibrates. So again, I don't know what part of the world is this patient in, but again, bezafibrate is not available in the US. It's available in Europe and in other parts of Latin America. So yes, it's an option. But also, for example, I'm very kind of keen in using something called rifampin. It's a TB medication that I've used with a lot of success and really treats really properly the itching. So again, we do have other options. I think cholestyramine is kind of the first choice when it's really, really mild. But once you get to that mild to moderate where you're not able to sleep or even actually do your daily, kind of life activities, I will actually be in favor of using other type of medications.
Great, thank you. Patient who's been on URSO since November last year, and their initial liver tests were all normal. Their latest LFTs, that their ALT is raised at 144. GP has asked them to stop ezetimibe for high cholesterol. I don't know if I've pronounced that correctly, but with no plans to redo test. Is this a suitable response? Their gamma GT is also abnormal.
I mean, this is a tough question, and I want to say personally, I've studied the safety and use of statins, which is medications to treat their cholesterol in patients with PBC, and they're completely safe, and they do not cause any really harm. And also, it's kind of important to understand that cholestasis basically is when patients have an elevated alk phos, they have elevated cholesterol. As you treat their PBC, you can see their total cholesterol coming down. Again, sometimes what I do is, unless they have really significant risk factors, the patient has diabetes, heart disease, or something else, I'll wait a couple of months to see the UdCA really kind of, as they respond, cholesterol comes down. So again, I don't know the clinical scenario, but I think we would actually advise to look at with the physician to see what's next to do if we need to stop or not to stop the statins.
Great, thank you. That is a question we get quite regularly around statins, so that's good. PBC patient diagnosed in May. On a few occasions, they're having some spasms of pain, muscle pain. They think it might be connected to too much grease in their food and perhaps too much sugar on another occasion. Could it be right to link it to diet that might be causing the pain for them?
I would say it's very unlikely, but again, without knowing the complete medical history, I cannot comment or cannot answer the question. Something that is kind of important when people develop cirrhosis, the PBC has evolved, caused severe damage to the liver. Patients can get muscle cramps as part as a complication of liver disease. So that's something that I would be worried. But again, I just don't know the case, so I can't comment or cannot answer that question.
The full details, no, I understand that. Patient about to undergo 6 monthly injections for osteoporosis. Is there any concerns that might affect their liver adversely?
No, and it's very encouraged to do that because patients with PBC will have really severe bone disease. And if they don't get ahead of that, they can have severe fractures affecting their quality of life.
Great, thank you. Question about naltrexone, 4.5 milligram compound drugs for helping with autoimmune disease in general. What's your thoughts on that?
I don't use it, but I use naltrexone as treating itching. So
Yeah.
I would say I don't have any experience using as a treatment for the autoimmune disease, but I have experience using it for itching.
Great, thank you. Patient asking about HRT. So they're asking about testosterone when you're going through perimenopause. They're on HRT now after waiting 3 years, but I've been told it's not advised. They're on Urso 1 gram a day. So I think that's a general question around HRT and PBC, and potentially if it's safe to use. Yeah.
Again, a complicated question. I would say also we need to kind of balance between the risks and the benefits with the patient. So as you know, HRT is linked with increased risk of cancers, breast cancer, also increased risk of clots. So I don't know the patient's risk. But again, for example, if you look at data looking at osteoporosis in patients with PBC, we know HRT works, helping kind of like improving the mineral density in those patients. But again, I personally don't I'm not in favor of using an HRT because the risk that I just told you, but I think this is something that needs to be addressed and discussed with the patient, looking at risks and benefits together.
Thank you. When Urso is declared to be working in a patient, does that mean that their blood work should all return to normal range or is close to normal but not perfect range? I like this question because we're aspiring for normal, but yeah.
So, and I'm happy you're actually laughing because I think the PBC people are trying to change the guidelines, and we were trying to say what the new normal should be completely normal, but right now the new normal is not normal, right?
Not yet.
The new normal is, I think, as I said before, is responders are considered people who had an elevated AP and now is below the 1.67 threshold of the upper limit of normal. Again, we think and we are advocating that this should be changed, that should not be less than 167, should be going back to completely normal. But again, until we change those guidance or the guidelines, I think right now we can say a responder is someone who actually went below the 167 of our upper limit of normal.
Great, thank you. I'm just going to swap over and just check what we've got coming in live as well. We've got a few questions coming in live. I'll take the one that's in the room with us here at the moment. So we've got a patient asking if PBC patients can safely take steroid nasal sprays.
The answer to the question is yes.
Perfect, thank you. A patient on Facebook's asking about intermittent fasting. Is it helpful for PBC?
I would say it has nothing to do with PBC. So, if it's helping with weight loss, I'm fine with that, but it has nothing to do with the PBC.
Specifically for that. Yeah, there is actually a question about HRT that came in just ahead of I asked that other question. Can you take estrogen patch and progesterone pill with PBC?
The answer to the question is yes. And again, I just want to go and reemphasize the importance of evaluating the risks and the benefits of that case. Again, I am a believer that, HRT is linked to increased risk of cancer. Again, we need to make sure we take a family history. We need to make sure we take a good history because, again, there is an increased risk of clots, increased risk of stroke, increased risk of heart disease. But that needs to be evaluated, discussed with the patient, and then with the risk and the benefits. And then a decision between the physician and the patient, I think, should be assessed to see if this is in favor or not.
Of the benefits, yeah. Patient who's after swollen eyelids saw an optician and was diagnosed with very, very dry eyes. And she's been given drops for that. She's asking if it's related to PBC.
Awesome question. And the answer is we mentioned the top 3 symptoms, right? But again, other symptoms such as Sjogren's disease, dry eyes and dry mouth are also very common in patients with PBC. 20-30% of people with PBC will develop Sjogren's. So yes, I think this is related. I had patients with Sjogren's who we actually diagnosed PBC because that's also go with the autoimmune kind of pattern of disease. So yes, the answer to that question is yes, definitely could be related to not related absolutely to the PBC, but is related to the autoimmune kind of pattern that the patient has.
Okay, thank you. Patients had PBC for the last 10 years that they know of, but they've also been asymptomatic. Now have arthritis in both knees and in a lot of pain. Can they take ibuprofen when it gets bad? And also questioning about CBD oil.
So I would say the first thing is staging of their liver disease. If the PBC has not caused any damage and they have normal liver tests, I do not see any contraindications for, we call it NSAIDs, ibuprofen, again, just to make sure that they're not anticoagulated, not taking aspirin, because that puts the patient at risk of having an ulcer or hitting the kidneys. But again, from my end, it should be okay. And for a CBD oil, I have nothing against it, so I don't think that really helps. But if patients have some type of relief with that, I'm all for that.
Great, thank you. Patient has been having a bit of a bad time over this last year. They've had urosepsis 3 times, also urine is at emergency level with calcium, so they've got kidney stones, and they're asking, is it true PBC patients have a higher risk for UTIs? Also, I'm reading calcium high in urine, maybe an overflows from intestines.
Great question. So I would tell you the other way. So what we know, what are the risk factors for PBC? Frequent urinary tract infections and studies have been shown to be a risk factor for developing PBC. We really don't know why. But does PBC cause urinary tract infections? The answer to the question is no. The other thing to consider, when someone has kind of kidney stones and, for example, they have PBC, the other things to consider, does the patient have inflammatory bowel disease, Crohn's, ulcerative colitis, that can cause absorption of calcium, kidney stones. But again, the question is if this is absolutely related to PBC, the answer is no.
Thank you. Question around when a patient's only on urso, their ALP is slowly going up, but when they're on steroids, methylprednisolone with urso, their ALK phos goes way down. They do not have autoimmune hepatitis. Both liver doctors they've seen over the last 3 years says steroids does not have a bearing on PBC, but from the studies they're reading, they're saying that it can work alongside urso. Any experience?
I'm going to be along those two PBC physicians. So we know that steroids don't work, decreasing the ALP. There's a subset of patients that they have kind of a tied up overlap between autoimmune hepatitis and PBC, for example, in the studies, but they gave budesonide, and then those AST and ALT, but not specifically ALP, start actually coming down. But I would say I don't think that dropping the ALP was related to the steroids. But really good question.
Thank you. Patient who's due to start elafibranor, as all the other medications they've tried has either stopped working or has been causing kidney issues. ALP has been steady from 400 to 800 in 4 weeks. So they're asking if they can take rivampicin with elafibranor due to the severe itch. I'm just looking because there's been another comment put on to say bilirubin 9 and FibroScan 8.3 in August. So the ALP has increased from 400 to 800. And if they're starting elafibranor, can they also take rivampicin for the itch?
The answer to the question is yes. I would say with a caveat, right? So first of all, elafibranor is one of the new medications that was just approved this summer, both in Europe and the United States. It's a fibrate, and basically it's a PPAR agonist. And then in studies has been shown to improve both disease activity and some patients symptom-based, specifically the itching. And I would say mild to moderate itching. So I think with the ALK phos going from 400 to 800 is really a good idea to start this therapy because again, in the studies, we've seen patients respond significantly to this medication. The next thing is elafibranor can increase the creatinine. So again, if the patient has underlying kidney issues, that's something that needs to be watched very carefully. And finally, I've used a combination of rifampin and other therapies. The things with rifampin, they need to monitor closely the liver test because they can cause liver toxicity. So again, I'm not worried about it, but patients should be monitored closely. And finally, that elastography for FibroScan 8.3 tells me that we have good amount of time to get the right therapy for that patient because although the patient is kind of not zero staging, but is basically stage 1 to 2. So I think we have the time to get it on the right therapy, get the patient under control.
That's great, thank you. We've covered this a little bit already, Doctor, but the patient that's asked this is just, I think, has just joined the sessions recently. And she's asking, is AMA test enough to say a person has PBC? Unfortunately, their daughter did test positive for that test, but her ALP and other tests are normal. Thank you in advance. I think it might just be worth covering it again in terms of the ALP and the positive AMA.
Yeah, but again, it's an important question. So currently the guidelines say that to diagnose someone with PBC, you need to be 2 out of 3 of the following. 1, you have an elevated alk phos. Number 2, a positive AMA or any other antibodies related to PBC, SP100, GP210, all those can be positive. And finally, if you don't have any of those 2, a biopsy findings of PBC. So you need 2 out of those 3 to actually diagnose with someone with PBC. And as we said before, if someone has a positive AMA with normal liver test, there's 2 schools of thoughts. One is follow the liver test to make sure they don't develop an elevated alk phos, or preemptively using UdCA because there is an increased risk of getting PBC in the future. So again, both kind of things to do are pretty okay to do.
Great, thank you. And that's us. That's the questions that we've had in live so far. So I'll keep an eye on that. So I'll pop back to the questions that we've had sent in. So we've got a patient who's asking about, they've been told that colouring is not good for health. So they're asking about yellow colouring being added to urso. Is that harmful?
I have no idea, but I would say no.
Good for me. Patient who's been taking urso for 6 years and tolerating it well. Is there any need for discussion about changing to UdCA or other drugs?
As long as the patient is responding and the patient has no advanced features, they need any ALP, elastography, or any type of liver disease, the answer is no.
Thank you. And a general question around PBC and also autoimmune conditions being hereditary. Patient who has been diagnosed with PBC, there's also some other family links around other autoimmune liver disease. Is there likely to be a hereditary connection, or is it just a coincidence?
Great question. The answer to this question is yes. So we've seen a genetic predisposition developing PBC. So when a patient comes to me and diagnosed with PBC, it goes really kind of like in the female inheritance. So again, if you have a first-degree relative, which is female, that risk is actually 20%. So I usually do some genetic counseling in the clinic. So I tell them to actually get those family members tested with a positive AMA to start looking for PBC. That does not go the same with male gender. So the male gender is really close to 0 to 1%. So based on that, I don't recommend screening them for PBC because it's not really worth it.
Great, thank you. Patient asking about PBC causing trouble sleeping. Is that something that is linked? And if it is there something that can help?
I would ask the question, are the patient having any itching? The answer is yes, then yes. Can PBC cause problems sleeping alone? I would say my guess is yes, but I don't have really good evidence about it. So again, it depends. I will have to actually do a little more investigation into that symptom.
It could be the itch that's causing the sleep disturbance. Yeah.
Correct.
I'm just reading through this question first. We've got a patient who is asking how they can get a referral from their general practitioner. Despite having lots of blood tests and results are out of range, the most concerning one is their high ferritin and TSAT levels, low platelets. They've been diagnosed with PBC amongst a few other things with their liver, have been gene tested R69 panel. All 4 types are so far negative and DNA is still being sequenced, results not back yet. They've had no treatment yet. They had itch, which seems to have calmed down, but it started up with a vengeance over the last 4 months. I think they're just concerned about the next, what should they be encouraged to do in terms of asking for a referral to a specialist?
I mean, that would be my first advice. I mean, they need to see a hepatologist. I mean, it sounds when someone has, it's called iron overload, that's hemochromatosis or other type of iron disorders of the metabolism. So I think maybe sometimes these cases will need a liver biopsy to quantify the amount of iron, but has nothing to do with PBC.
Great, thank you. Just keeping a wee eye for questions coming in there. So we've got, can patients with PBC, are they able to donate blood? I don't think we've been asked that question before.
Well, the answer to the question will be absolutely yes. Unless they have cirrhosis or anemia, I just don't see any reason why not.
Great, thank you. With winter approaching, low vitamin D due to lack of sun. Is it okay for patients to use sunbeds despite the normal cautions to everyone using them?
I cannot recommend that. We know that sunlight and UV light can cause skin cancer. So, you need some type of sun exposure for your vitamin D, but I cannot recommend that, unfortunately.
Thank you. So we've got a patient who's post-transplant who normally gets their meds in nomad trays, so their medication's all made up for them in advance in their boxes. But they've recently been told that their tacrolimus and their mycophenolate shouldn't be going in the tray. It should be staying in its original packaging until the patient's ready to take it. She's worried that by not doing that, she's worried she'll forget to take them. But I think she's just asking the reason why if they shouldn't be taken out the original packaging early, and if not, why not?
Again, post-transplant, my only thing the only thing that I can think of right now is basically they're changing the dose because, we monitor kind of the levels. So sometimes what we do, we have a lot of patients using those blister packs here in the US. And again, we have to call the pharmacy every week changing the dose. So that actually changes based on the levels on a weekly basis. I don't know how far the patient is from transplant. So it depends also the time the patient was after transplant.
They're well past transplant. Transplant was in 96, so a lot of years post-transplant.
I think the levels should be really low. I don't see any reason, but again, I think we'll have to really look into this case to give a really kind of proper answer.
Yeah, I hadn't thought about that side of it actually, because I know just after transplant your numbers can change, so then you'll get a call to say change the dose. So I hadn't thought about it from that perspective. I think there was just a concern that by taking it out of the original packaging, that somewhat damages the medication before you potentially get, if it's in your box for a couple of weeks or something before you take it.
Yeah.
Great, thank you. So another question that's came in live here, we've got a patient whose doctor is with Mass General and Brigham in Boston, local for you, recently did a test for fibrosis and it came back out of, I think we're missing some of the question there. Wait a minute, sorry, apologies, we're just getting a wee bit more context on that. Did a test for fibrosis, but it came out of FO. Is that standard, or are we missing something for the question?
Yeah,
there? I think we are. Because then it goes on to say, could you please tell me what your thoughts are on this test accuracy? So if I can just ask that person to clarify for me as to what happened after the test for fibrosis.
Yes, that would be my advice too.
The test was a blood test. I forgot to mention that. And then cancerosis improved with diet and weight loss. So just a bit of clarification, if you can give us a bit of clarification around that information you've put in there around your fibrosis test. I think there's something that's not quite came up correct in the comments here on Facebook.
And also happy if they, I'm in Boston, so happy to see them in person too if they want me to.
Oh, that's special treatment. I don't know about that. That's how do we all queue up for that? I think that's what happens when it came out F0. It's not FO, it's okay. F0. Right. Yeah.
So then where the treatment is working, so there's nothing else to do. So again, maybe don't need to see me, that frequently.
Too late. That offer's been made and recorded. So that, thank you for that. That's great. And thanks for clarifying that. That was great. It was just to make sure that I was on the right track there. It said I had read it FO, but when it came back in, it's F0. So that's great. So we've got a patient asking about information regarding PBC and blood pressure medications. There's so many. What would be the best one to take? They've been on amlodipine and recently been changed to candesartan. Is one considered okay with PBC, or is it dependent on the individual and the circumstances?
I think the second. Again, there's no issues with PBC and blood pressure medications. So whatever the cardiologist, primary care, whatever who's involved, taking care of that blood pressure should be able to use whatever they want.
Great, thank you. We touched on statins earlier, but another question around just in general, the statin leaflet says not to take it if you have liver disease, so their doctor's taking them off it. But I think that's quite a general thing to be mentioned in a lot of medications, isn't it? So I think it would need to be looked at on a personal level, just rather than a general no. What do you think?
Again, I'm with you, Mo. Again, it's just like the first thing is, as I explained in kind of early in the video, is PBC where the cholestasis are associated with an increase of cholesterol levels. So those patients who don't have major risk factors, when I say major risk factors, they have diabetes, kidney disease, heart attacks, or strokes, usually what I do is I'll give them the UdCA and I follow those cholesterol levels over the next 3 to 6 months. And then as you improve in your cholestasis, your AP, ALP, you see the cholesterol levels coming down. It is also well known that patients with PBC have an elevated cholesterol, but they have a good cholesterol always up. So you look at the kind of patterns that you have, your total cholesterol is up, your LDL is up, but your actually HDL, which is the good cholesterol, is significantly higher. So PBC by itself is not a really increased risk of heart disease. This is when you combine with the other risk factors. And then, you have to balance the risks and the benefits, right? If your bilirubin and your alk-phos are elevated, yes, I agree. Those patients should not be taking statins because the risk of increased hepatotoxicity, liver toxicity. But if the patient has normal liver biochemistries or mildly elevated liver tests, remember, the risk is there is no heart, there is no liver. So the heart always takes precedent, and we want to make sure that we, based on the risk profile, patients should be taking this type of medications.
Great, thank you. It is a question that we get quite regularly, actually, is around that. Patient who say they were very fortunate to receive a liver transplant 9 months ago, and they suffered with SICA prior to op, and since the op, they've had intermittent, quite strong dry cough. Could this be SICA now affecting my throat, or is it likely to be because they're intubated in ICU for 2 days post-op? But bearing in mind it's been 9 months since their operation.
So it's hard to say that this is related to the intubation 9 months ago. I think SICA also, it's hard to say 9 months ago too. So again, this is the time of the year, but all the viruses are out. So I want to make sure there is, we call it upper respiratory infection, but again, I don't think it's related. I mean, there's all blood pressure medications that can cause cough, So again, I will have to look into the detail to give you an answer, but this is not related to PBC or the intubation after transplant 9 months ago.
Thank you. I'm just having a read through our questions here. We've had patient who's having regular sinus pressure and headaches for around 6 weeks, wondering if it could be connected to their PBC. They're only on ours, so they've not had their first full consultation yet.
No.
No, perfect. Thank you. We spoke a bit there about SICA. So we've got a patient who's having really bad dry mouth, particularly in the evenings. They've got a saliva spray replacement, but it's not helping as much. And as I say, night times are particularly bad. Anything else that you might suggest to help with that?
Just increase, intake. Water intake is the most important therapy for SICA syndrome. Unfortunately, we do not have really good therapies for this.
We have a patient who's thinking about taking part in a fatigue study that's running at the moment for Golexolone, and they're just asking, would this be, she's 45 years old and just a bit worried that potentially it could cause her disease to worsen. But I think it's worth just commenting that this study is specifically for a symptom and not for disease progression. But I just thought it'd be worth mentioning it to you, Doctor, to see if you had any views on that.
I think this is one of the most controversial things that we have right now in PBC, right? So we have really good therapies for disease activity. We have 2 new meds and maybe another 6 coming out. We have really good medications for itching, 2 new ones, another 6 coming out, but we do not have anything really kind of important for fatigue. So what we've shown in studies that really helps with fatigue is exercise, right? Moving. So I usually tell my patients is, get moving, you need to break the cycle. I rule out organic causes of the fatigue, make sure they're thyroid, they're not anemic. And again, there is depression related to the PBC, but also there is severe fatigue. If I remember correctly, there's only kind of 2 studies called the NOX inhibitors, one of those medications that actually show some improvement in fatigue, but currently we do not have an efficacy therapy to treat this symptom, unfortunately. So anything that patients can do to enroll in studies so we can get more data will be really appreciated so we can actually answer those questions in this type of forums.
Mm-hmm. And that study is actually actively recruiting in the UK and moving into Europe shortly. So we've been working closely with the company. If anyone's interested in some more information on that, if they email me at mo@bbcfoundation.org.uk, I can share some additional information about that as well. If you let me know that you're interested in the study, I can share some more information on that. I'm just taking another patient question that we're getting coming in here. Just patient as well saying thank you for the answer that we gave around the fibrosis question there as well. A question in general, is there a point where the liver can no longer regenerate itself? Or is there no tipping point? Which measurement is the most accurate? I have a FibroScan result of 26.3 kPa with an IQR of 9%. And since my spleen appeared enlarged, a CT has been ordered.
Good question. So I would say what we know today in the kind of liver world is everything is reversible until you get to the cirrhosis stage. Once you get to that stage, we know that this is basically no coming back. So stage 0, 1, 2s, and even 3s, I've seen patients getting treatment for their conditions, and then their liver tests actually improve and their FibroScans or biopsies improved. In a case where the FibroScan elastography of 26, that means in a setting of PBC that there is cirrhosis. I would say it's not reversible, but I would say is I have a lot of patients with cirrhosis who have a really normal life. So we know that if we get them treated and we keep them stable, they really have no major issues. So the only kind of things that we need to kind of remember is those patients are an increased risk of liver cancer. So I do see them twice a year, and I get an ultrasound and a blood test to make sure they don't develop that. And 2, they're an increased risk of varices, big veins in the esophagus they can burst. So I do an endoscopy every 2 to 3 years. But besides that, if they're compensated and they have really good normal liver numbers, then it's just there's no reason to panic, and then you just follow them every 6 months in clinics. Great,
thank you. We were talking earlier about disturbed sleep. So a patient's asking, can mild splenomegaly cause left upper quadrant pain and disturbed sleep? I'm getting tested on my pronunciation this week, I'll tell you. So they're asking if that can cause left upper quadrant pain and disturbed sleep.
So yes, it can cause some type of discomfort, but I have never seen it or causing severe sleep disturbances. So I would say from my end, again, I've never had splenomegaly, so it could be uncomfortable, and if the patient sleeps in the left side, could actually make it issue, but I don't see that causing sleep disorders.
Great, thank you. Is metformin okay for patients with PBC?
Yes.
Great. And we've done that one. Just when we were chatting there about cirrhosis, so we have a patient who has cirrhosis due to PBC. Is there anything they can do to reverse the cirrhosis? I know we've just had a bit of a chat about that, but it's just because there was a specific question there.
Again, and I want to, it's just like, people really panic when we're using the word cirrhosis, right? Because, it is, you get the stigma, you get panic, do I need a transplant? So in my clinics, I have a lot of patients who have cirrhosis, but they're compensated, right? So they look like me or like Mo right now, and they have no issues except their liver is kind of completely scarred, and that's what we call cirrhosis. As I just mentioned, those patients are an increased risk of liver cancer or bleeding from varices, but we do screening tests on them every 6 months, and that basically is the only thing that I need to do for them. If you're becoming decompensated, I mean, you're already developing symptoms of advanced liver disease, you get yellow in your eyes, you get fluid in your belly, fluid on your legs, that's the time to start thinking about a liver transplant. So it depends what stage of the kind of cirrhosis you are. But again, I have a lot of patients who really kind of come to see me once or twice a year, and that's basically it.
Great, thank you. That has come to the end of the questions we've sent in. And I was also, when you popped off to get the phone there, I was just saying to our patients that we had quite a backlog of questions. But thanks to you today, we've got through quite a bit of that backlog. So that's brilliant. Thank you so much for that. It still amazes me how popular our Q&A sessions are, and we do have a lot of questions coming in, and often if we don't get to everything that comes in live on the day, we end up getting a bit of a backlog for people sending them in as well. But we've done really well today, and we've got through lots of them, and I really appreciate your time for that. I will also just take the opportunity to mention, if there's anyone watching, that we are working with Dr. Bondar to look at doing a Spanish Q&A special as well, which we're hoping to do later in the year. So keep an eye out for more information on that. So we're hoping to do a general presentation in Spanish on PBC and then have a Spanish specific Q&A as well. So we'll get the details of that finalised and then published for our patients as well. So thank you so much for taking the time to join us again, Dr. Bondar, and I look forward to seeing you next month when we're at ASLD.
Okay. Thank you, Mo. And again, appreciate everyone's time and happy to answer all the questions, and I'll see you again soon.
We will. Thank you so much for that. Take care.